in few minutes the interoperability to the students master levels. I can see that in master levels, most of the time engineers are teaching without any clinical examples. So this time I'm going to teach students about clinical examples and how interoperability works. Let's see this screen. Here's a healthcare interoperability. We just need to know some clinical scenarios based learning. HL7, V2, FHIR, FHIR, EHR, and EMR. So there's no code at all here, okay? There's a very simple explanation. HL7, V2. See how does that look? FHIR R4. Querying medical history. Let's see what happens in Kathmandu when all the hospitals like TU, Bhaktapur, everything is interconnected for the national immunization systems. So let's start with one patient, Bhagavati. Okay, so the ecosystem just look like that. Now, Bhagavati is admitted to the emergency department. She came from another hospital. Okay, and now she registers, then the system broadcast, then there's a FHIR query, there's a lab report, there's a transfer. Okay, so the patient is admitted. Now, what happens at the back end at the engineering level? See, the clerk enters and record ADT. Okay, how system broadcast? The HL7V2 message sent to lab, pharmacy, radiology, and billings. Then there's a query. The emergency department physician queries the Birat hospital because she came from Birat, so there's two hospitals. So now the lab report says the troponin is elevated. Lab sends ORU back to EHR. So I'm quite sure that the students know what is ORU, ADT, and all this. And now the Bhagavati is admitted to cardiology. So ADT broadcast updates all downstream systems. Okay. So let's see how HL7V2 messaging works. Now this is the actual message that fires when Bhagavati is admitted. Okay, it uses pipe, delimiters, and segmental codes. It looks like this. I'm quite sure students learn that. Okay, it looks cryptic, but every field has a precise meaning. Okay, let's see how it's decoded. See, patient identification, patient visit. Okay, let's see segmental guide. Now I see that UVN, PID, RBX, and all that stuff. Now FHIR with API call, FHIR in action. How does it query medication history? Now the doctor in the emergency department is asking, hey, what were the medication used? So the real API call from Gangalal Valley is admitted to Birat Hospital's FHIR endpoint. Okay, the message is pushed in between the systems. The FHIR uses HTTP REST. So boom, you see this? All the key concept is that Birat Hospital's local ID is different from where currently now Gangalal is admitted. So there is a mismatch in between ID. So we have to be very careful. Just knowing FHIR is not enough. So once implementation is very important. Okay. See the request and the FHIR response. The key resources. We already talked about that now. Let's see the gaps. Interoperability gaps. Okay. The gap between the standard and the reality. Knowing how to code is not enough. So there is a standard exists, but healthcare data is very much fragmented. There is a patient identity mismatch in between two hospitals. She is now in Gangalal, but she came from Birat. Okay, So the terminology is fragmented. One system sends diagnosis code in ICD-10, the another may be in SNOMED CT. So HL7 V2 is technically a standard, but implementations vary enormously because so FHIR implementation gap. There's I think you know this, the Cures Act, the ANC rules. So I want you to look at these things. But currently, it adds authorization to top FHIR, third party act. See how it bundles up now. When the patient is discharged, the FHIR bundles up. This is what CDA, the older XML format, does. But in FHIR, the bundle is what sent to Virat Hospital, the regional health information exchange, and potentially Bhagabati's own patient app. So now let's see another example of vaccination data exchange. So intra-hospital is in between one hospital. It's very easy. So there is a registration, there is immunization clinic, one EMR, the pharmacy, the vaccine inventory, and the billing. And it's not that hard. But the key point here is inside one EMR, 5 resources still get created. Now, let's see. When there are 5 hospitals and all the vaccination reports is going to one national immunization information system. So central FHIR repositories. Here comes the problem, okay? So what each hospital must do before the data leaves the building: map the local ID to national ID, standardize the vaccine code, conform to FHIR R4 structure, authenticate over the network. Now in posting to the central FHIR repository, like this. So just talking about FHIR, is not enough. You need to have a clinical knowledge, the implementation of EMR, the project management part, the data science, where the data resides, how it travels. So everything is important. So the HL7 version 2, FHIR R4, the Kathmandu scenario we all talked about. So we are 5 hospitals and one national immunization information. And we also talked about the Bhagabati's ED emergency department journey. We talked about the ecosystem. The HL7 V2 is the standard. The another is FHIR R4. We have the EHR enterprise. We have EMR clinics. So we also talked when Bhagabati was admitted. We talked about the messaging. We talked about the API. We talked about the gaps. We talked about the FHIR building. We can test ourselves also, about creating different clinical scenarios. Like for example, we can create one scenario like the lab results arrives by HL7 ORU, but the patient can't be matched in the EHR. What are the risks? So there is a lot to learn, but it is very, very simple. So do not start coding without learning what happens in the hospital. Thank you.